Good afternoon, and welcome to the second meeting of the Assembly Committee on Health and Human Services in the 82nd Legislative Session. Madam Secretary, welcome back. Please call the roll.
Assemblywoman Gonzalez.
Here.
Assemblywoman Gorlow. Assemblyman Gray.
Here.
Assemblyman Hafen.
Here.
Assemblyman Hibbets.
Here.
Assemblyman Koenig.
Here.
Assemblywoman Newby.
Here.
Assemblyman Nguyen.
Here.
Assemblyman Orentlicker.
Here.
Assemblywoman Taylor.
Present.
Assemblywoman Thomas.
Here.
Chair Peters.
I am here. Please mark Assemblywoman Gorlow absent excused today. Today we have presentations about Nevada Medicaid and Welfare and Supportive Services from the Department of Health and Human Services. Thank you so much for being here. A couple housekeeping things, as always, just so we're on the same page as we're getting going. First and foremost, please silence your phones, laptops, etc., pagers, any kind of device you might have on you that will ding during our committee. Double-sided pages, trying to save some paper. Make sure I hit everything on here. Members of the public may provide testimony in various ways, all of which are listed on our agenda. Today, we will have public comment period towards the end of the meeting. You may also submit public comment in writing, either in addition to testifying or in lieu thereof. Written public comment may be submitted before, during, or up to 24 hours after the meeting's adjournment. If you wish to testify in person, please sign in at the table by the door and leave a business card so we can track who all is here and your names for our recording purposes. Anyone who would like to receive electronic notifications and access to the committee meeting material can sign up on Nellis, our legislative website. And to ensure an orderly flow of discussion, all comments, questions, and responses must go through me. Also, committee members must be recognized by me before you can speak. When testifying in person, please turn the microphone on to speak and off to listen, because we have others listening and we get some feedback sometimes. With that, we'll move on to our agenda. First, we're going to start with a bill introduction, a committee bill introduction. This is going to go similar to our last meeting. A vote to move this as an introduction does not commit you to anything related to this bill. Just allows us to introduce it on the floor. This bill, BDR 331, related to revises provisions related to substance use disorders. Do I have a motion to introduce BDR 331?
So moved.
Very many of them. Thank you so much. I'm going to take a motion from Vice Chair Orentlicker and a second from Assemblywoman Gonzalez. Are there any discussion on the motion? All those in favor, please signify by saying aye. Aye. Any opposed, nay? The motion carries. Thank you so much. Now we'll continue with our overview presentation of Medicaid and social services programs in Nevada. Please welcome Stacy Weeks and our administrator. Thank you so much for being here today. And we have Deputy Administrator, I forgot to ask how to say your last name. I'm so sorry. I'm going to let you introduce yourself so I don't butcher it on the record. Thank you all so much for being here today. I'm going to go ahead and pass on to you. Please proceed when you're ready.
Thank you, Madam Chair. Good afternoon. I'm Stacy Weeks. I'm the Administrator at the Division of Healthcare Financing and Policy. I have here with me today Deputy Kelly Cantrell with the Division of Welfare and Supportive Services, and also Deputy Sandy Rubelid, who works with me at the Division of Healthcare and Financing and Policy. Hopefully you guys can see these slides okay. I'm going to go ahead and just get us started. So today we want to give you a little bit of an overview of Nevada Medicaid and talk a little bit about our role at the division, as well as our sister agency, which we often refer to as DWIS. And then talk a little bit too about the federal public health emergency and the unwind process, which has an impact on our program. And at the end, we'll follow up with some, Thank you for that assistance. Thank you. We'll follow up with some updates from DWIS as well. All right, so this slide here sums up at a high level the impact of Nevada Medicaid's program. As you can see, about 920,000 people are currently covered by the program. In a previous presentation, I said 1 in 4. It's actually 1 in 3 Nevadans who are covered today by Nevada Medicaid. Something that we often hear about, is how much does Medicaid pay and all the different elements of it. But it's important to always remember it's a taxpayer-funded program. And we'll talk a little bit later in the slide deck about the financing structure. There's also, in the last 3 years since the pandemic, and because of the public health emergency and some of the continuous coverage requirements, we've seen about a 40% growth in the program in Nevada. And this is similar across the country, but Nevada's is definitely a large portion of growth. And Deputy Sandy Rubelid will talk about the public health emergency and the unwind process later in the presentation. Also, it's something that important to remember that there is still about a 10 to 11% uninsured population in Nevada, and we think that about 37% maybe are still the uninsured or likely eligible for Medicaid coverage. This data comes from the Gwen Center, which was the last real study that looked at this portion of the uninsured population. That study was from 2019. So we do think that number is probably different, but we do expect, though, a good portion still of the uninsured to be actually eligible for the Medicaid program and not yet enrolled. So these are some of the key statistics about the Nevada Medicaid program. As you can see, plays a very significant role in Nevada's healthcare ecosystem and our state budget. So for fiscal year 2022, Nevada Medicaid, the spending on medical expenditures and all the programs was about $5.5 billion. And that's nearly 30% of all state expenditures in the state of Nevada. About half of births are covered by Nevada Medicaid. That's 1 out of every 2 births in the state. About 78% of the people enrolled in Medicaid are served by 1 of 4 Medicaid managed care plans. And we'll talk a little bit in a minute about what is managed care and why is it different than our fee-for-service program. About 44% of the population are children. People forget that a lot of our enrollees are young youth and children up to the age of 18. 10% of our population are dually eligible, which means they're eligible for both Medicare and Medicaid, and that's about 91,750 individuals. 80% of the population lives in Clark County. That may not be a surprise to many of you, but it is a very big portion of the program. 62% of the nursing facility stays in the state are covered by our Medicaid program. And then 62% of the percentage of is the percentage of adults that are enrolled in Medicaid who are employed. So often we think of people being unemployed on the Medicaid program, but actually some data that Kaiser put out showed that about 62% in Nevada are employed. 64% of the population are people of color. Go to the next slide. All right, so we'll take a little step back here and look at how does Nevada Medicaid operate and kind of some of the oversight and the operations that are for the program. At the high level, we have our federal agency, which is the U.S. Health and Human Services Agency. That agency has delegated its authority and function to the Centers for Medicaid or Medicare and Medicaid Services, which we refer to often as CMS. Under Title 19 of the Social Security Act, under that, it was what established Medicaid back in the 1960s. And this program has been run by CMS, and it's overseen by CMS. And they oversee our program and often audit us. We have to go through them for approvals for federal share. And every state who elects a Medicaid program has to have a single state agency. In our state, under state law, that's the Department of Health and Human Services. Catch up here. What state law has done is delegated under the director of our department the the Division of Healthcare Financing and Policy, which is my division, and then also DWIS, our sister division. And you can see the functions here laid out in front of you at a high level. I will say there's a lot other things going on here, but these are the key core functions of each of our divisions. DWIS is mostly focuses on, for purposes of Medicaid, eligibility and enrollment, and that is the function that they play for the state. Our division focuses on Medicaid, the budget, so we are responsible for ensuring that we are overseeing and we're good stewards of taxpayer dollars and following state and federal law. And we're also responsible for payments to providers and ensuring that those payments are made on time and meet state and federal laws. We also are responsible for enrolling providers in the program. It's different than licensing from our agency who licenses providers. We essentially enroll providers as long as they meet our Medicaid standards. There's also program integrity that we're responsible for, and that's essentially some of the items that either the state may ask us to do, but also the federal government. And then we also administer the benefits and develop the benefits and seek federal approval for federal funds. And I already mentioned that we do pay providers. So often you may hear in the public, at least, I mean, my mom still to this day says Medicare, that I work on Medicare. But Medicare and Medicaid are two very different programs, and it's important to sort of understand that distinction. So as you can see here on the left, Medicare is managed by the federal government only. There's no state, there's no state entity that an individual can call and ask about their Medicare benefits. Often we do get those calls and we have to say, sorry, you have to call CMS, right? And that's, a different process. It's also funded by the federal government and consumer premiums, in addition to some other funding streams, but there's the state share piece that you see in Medicaid. It also covers a different population, a little bit differently, that covers the 65 and older, which we do cover in Medicaid, but they cover different services. For example, they do not typically pay for in Medicare long-term care, which Medicaid does pay for. Medicare also covers some younger individuals who have certain disabilities. And the Medicaid is a joint program that's jointly managed and funded by the state and federal government. It's a partnership. It's funded at no cost to the consumer. The program is not funded, it's taxpayer funded, but for the consumer, when they're covered by Medicaid, they do not have to pay a premium in most states and not in Nevada, or cost sharing. They also Medicaid covers all low-income individuals regardless of age and people with disabilities. And like I mentioned earlier, Medicaid does pay for those long-term care services that are super important for our population who are older as well as disabled. And they are the payer of last resort. It's something that we often don't talk about, but that's an important piece. We do have, like I mentioned earlier, a dual eligible population, which are served by both programs, who are the seniors. So this slide just kind of gives you a high level of who is covered by Medicaid. These are mandatory populations in federal law. And so all states cover, to some extent, this population. And we'll look in a minute about what extent Nevada Medicaid covers this population. But it's all families and children who are low income, pregnant women and newborns, low income adults up to the age 64, most seniors, 65 and older, and people with disabilities, as well as children in foster care, guardianship, and adoption assistance. So in Nevada, when we look at what we consider low income, we have different eligibility limits. And it's a percentage of the federal poverty level. So when you look at, for example, on the left here, the Children and Checkup Program, children are covered in Medicaid, especially 0 to 5, are covered up to 166% of federal poverty. The difference here that you see, the 205%, the difference between those two populations is the checkup program. So we cover children farther up with the checkup program, which is our Children's Health Insurance Program, CHIP. And people and families have to buy into that program. Children who are 6 to 18 are covered up to 139% of poverty in Medicaid, and then CHIP makes up the difference, up to 205% of poverty. Pregnant women are covered up to 165% of poverty. I would note the governor's recommended budget includes a proposal to expand this eligibility up to 200% of poverty. And that is pretty consistent across the country. A lot of states are covering pregnant women, similar to their children population, up to 200%. Nevada Medicaid covers parents up to 138%, which is the limit if a state chooses to expand Medicaid, which Nevada did choose to expand Medicaid, the limit, they have to at least cover people up to 138% of poverty. So parents and childless adults are covered to 138. And then seniors and people with disabilities, under the ACA, their eligibility income limits were not impacted. And so they, as you can see, they're below the 138% poverty line. So they're down. In Nevada Medicaid, that's 74%, and it varies by state. Making sure I didn't forget anything in my notes. So this slide just looks at who is enrolled and how many people in the different categories. As you can see, more than half are our parents and children, so our families. It's a big portion of our program. The second largest portion is adults without children, and you might think of the Medicaid expansion population when you think of that population. And then the other two buckets here, as you can see, the 12% is our age, blind, and disabled population. And then the smaller portion here is the 6%, which is our child welfare, individuals who are adopted, foster care, and also our waiver programs. So how does someone enroll in Nevada Medicaid? There are several pathways to enrollment. We'll talk about that in a minute. But first, often most people don't want to go through that very long process. They just want to see, they just want to screen for eligibility, right? Should I even go through that? So there are three different ways people can kind of get into Medicaid enrollment. The first one is Access Nevada. So the picture on the slide there is the website, and this website is operated, and this system and software is operated by DeWiss, and this comes from their website. And people can go onto this website and do a screening to see if they're eligible before they go through the long application process. Nevada HealthLink, our exchange, our Silver State Health Insurance Exchange, also refers individuals who may be eligible for Medicaid to Access Nevada. That's another pathway. And then some people find their way to enrollment through a hospital or a qualified provider through presumptive eligibility. And what that means is that, for example, for hospitals that do use presumptive eligibility, they essentially presume someone is eligible based on the information they report. So their income, sort of what's going on, how many people are in their family, and they can presume eligibility. And when they do that, they submit an application to DWIS, and if they are determined, presumptive eligibility is approved, then the hospital can get payment for the services provided to that individual, even though they haven't gone through the full application process. Now, that enrollment is temporary. It's not permanent. That individual has to complete a full application within the deadline. And if they do complete and they are determined eligible, they will be fully enrolled into the program. And then here are the three other, I would think of the official ways to enroll in Medicaid. So again, Access Nevada is our key site. So individuals can go on that site and enroll and go through the full application process. They'd have to set up an online account. They can also, though, enroll by paper still and by mail. And they can also enroll in various district offices in northern and southern Nevada in person. So what does Medicaid cover? So we have two buckets here of benefits. On the left side here are the ones that under federal law, if states do not cover these benefits, they risk not receiving federal share. This is our mandatory minimum set of benefits that Title 19 established for state Medicaid programs. So we have to cover all of these services listed. And then on the right side are the optional benefits. So federal law does list out these benefits as being optional, and if states want to add them, they can seek a state plan amendment and add them and get approved. And then we will, in that process, we often define what's included, for example, under clinic services, what types of providers, and what the reimbursement methodology would look like. There are other benefits here. The font got too small, so at the bottom, as you can see, among others, and they are available on the CMS website. So often we hear, I think you guys have probably heard about, we just need a waiver. And often we hear a lot about waivers. And I think it's important to step back and think about what is the difference between when we talk about a state plan benefit versus a waiver. So they're really two different things. So a state plan benefit, for example, or coverage exists within federal law. So it's either mandatory or it's optional, and it's listed that way. And states can take it up, but they have to offer anything under the state plan statewide. Has to be available to everyone. It has to also be available in a comparable manner. So we can't give someone half the benefits we give others. We also have to offer it the same way to providers in terms of reimbursement. We can't pay the same qualified providers differently. You have to be fair. And the other piece of that is we have to allow freedom of choice for the enrollee in a qualified provider. So if a provider is qualified and they're enrolled, we have to pay for that service if it was covered and they were eligible. So that's a state plan benefit. So that has a lot of protections, right? So waivers waive a lot of those things, okay? So when you think of a waiver, you're thinking of, oh, I want to offer this benefit perhaps in this region of the state because maybe we want to try it out and see if it works, or we only have one provider, or it's a budget risk, right? So there are a lot of reasons states use waivers. So that's when we're operating within federal law, but we're also seeking waivers of federal laws. And so there's a lot of flexibility there. Nevada has several waivers. We have home and community-based waivers. We have 3 currently. We also have, we just recently submitted a waiver to add dental benefits for diabetic patients, and only allowing those benefits to be available in FQHCs, for example. So that's where you can see it's not statewide, it's not available to everyone, but it is allowing us to cover those services through a waiver if approved. All right. So how is Nevada Medicaid delivered today? So there are 2 systems that Nevada Medicaid uses that the state has chosen. The first one, as you can see here, is our fee-for-service program. When you think of the fee-for-service program, it's your historical program and how services have been paid for years in Medicaid. The state sets the rate and pays the provider directly per service. It does not reward for anything but volume, essentially, right? That's the way it's operated. It can be a risk to the state budget because of that, and so we'll talk a little bit in a minute about why states went to managed care. But that is the risk, right? Sometimes the costs are hard to control because there is no utilization management in fee-for-service. In Nevada, so as you can see here, the individuals that live in rural areas of the state, our waiver population, our child welfare populations, and there's one missing on here, I apologize, the aged, disabled, and blind population, they are all in our fee-for-service program today, and that's about 28% of our population that are enrolled. The second program that we have here is our managed care program, and this program operates in Washoe and Clark County, as well as Carson City. And in this program, the state contracts with health insurance companies to manage the cost, utilization, and quality of care for these enrollees. They develop the provider networks, they negotiate the rates, and they pay the providers directly. And I would just note that when you look at these 2 populations, even though the MCO side, 72%, it's a very large portion of the program, it does represent, though, a very small portion of the cost compared to the per member per month. When you look at how much the per member per month between these 2, fee-for-service is a lot more expensive. It's about $800 per member per month, the last data that we looked at in 2020, versus about $250 for the managed care program. And the difference is the fee-for-service program is often our higher cost population, and that it is hard to essentially do risk utilization and control for those costs in the managed care program. See if I forget anything. The other thing I would note too is that something a lot of states that you might hear a lot about is value-based payment design, and that can be a way of delivering services, but in Nevada Medicaid we are implementing some of that delivery into our managed care system today. We currently have targets and for value-based payments with providers, and essentially that's allowing us to pay providers and reward them for improving care, meeting certain quality metrics, and getting the outcomes that we want to see. And so we're hopeful that that will really start to change some of the payment models in that program. So how is Medicaid paid for? It's a state and federal partnership, like I mentioned earlier, under federal law, and the state shares in the cost with the federal government if something is matchable. The FMAP is the federal share, as you can see here. And FMAP, when I say that, I'm referring to Federal Medical Assistance Percentage, and that it's based on a formula, and it represents typically the per capita income of a state. And some states get more than 61% and some get lower. No state can get less than 50%. Nevada Medicaid is currently at 61% FMAP, so that is how much the federal government is willing to pitch in for the cost of the program. And the state share is at 39%. And as you can see, together, those make the provider payment. So will Medicaid pay for a service? So there's really, often we get this question a lot, and there's really 4, I think, helpful questions to answer. And if you answer yes to all of them, then then the service is paid for. So the first one is the individual enrolled in the program? So if that's yes, great. Is it a Medicaid covered service? Is it a Medicaid enrolled provider? And is the service medically necessary? And if all those 4 things, if you get a yes, then it should be paid for and we can draw down federal share to match for that service. All right, I'm going to turn it over to Sandy.
Good afternoon. I'm Sandy Rublet, a Deputy Administrator with the Nevada Medicaid Program. I've had the pleasure of being put in charge of the Public Health Unwind statewide, and it's been a lot of fun. As you can imagine, it's very complex to coordinate something across 3 different entities, so that's been a definite learning experience. So over the past 3 years, states have been under what's called a federal public health emergency, also known as the PHE declaration, due to the pandemic. And so that afforded states flexibilities in coverage and a continuous coverage requirement under Medicaid, which also afforded a 6% FMAP increase. So that was definitely a benefit to the state. Telehealth was one of the flexibilities that we do intend on continuing if approved by CMS. So we did submit that request to CMS and we are awaiting their approval. Some of the administrative flexibilities we've gotten approval for during this process is to use the U.S. Postal Service notice of change of address database and managed care organization as trusted data points to change someone's contact information without having to reach out to the member and verify the information. We're allowed to eliminate that step and ensure that we have good address and contact information for members. So under the Families First Coronavirus Act, continuous coverage requirement was tied to the expiration of the public health emergency. That was ended under the Consolidated Appropriations Act, and we actually got a firm date to end the continuous coverage requirement. Previously, we were operating under like a 60-day notice of, okay, it's going to be extended, it's going to be extended, it's going to be extended. So it is now ending on March 31st. So we will begin what's called the unwind process on April 1st. And what that means is we will start doing redeterminations for Medicaid eligibility. That process will transpire over a 12-month period. So it starts April 1st and it will end May 31st of 2024. And part of the unwind we will be reducing that enhanced FMAP over time, and it will be back to normal, as we call it normal, January 1st of 2024, but it is a gradual step down quarter by quarter. So the next slide is our projected Medicaid caseload. We do anticipate, to the best of our ability, that 200,000 members might be impacted by the unwind. Okay, so the unwind cycle, this is a visual of how this will occur. It's important to note that we did not stop doing redeterminations as part of this continuous eligibility. We continued to mail redeterminations packets. We just didn't take a negative action. If someone wasn't eligible, we continued their eligibility. So it's not like we have this big pile of members waiting to be redetermined. It's going to be based on their due date for redetermination, so that helps spread out the workload. So month 1, as you can see in this visual, is April 1st. And so approval notices and renewal packets are going to be mailed out day 1 of month 1 in April. And then we go through to month 3, which is June. So the first negative action will not occur until June as part of this unwind. And then at that point, you also have, the members also have 90 days to submit for reconsideration, like if they didn't realize they needed to return paperwork or anything like that, they do have that 90-day period. And so for the past 10 months, we have been doing some extensive planning because the goal is to avoid loss of coverage. I think that's the really key factor here, is to, if members are no longer eligible for Medicaid, then they need to have a soft landing place. And so that's where the exchange is a really important partner with us. So we've been working very closely with all 3 agencies to make sure that we have that covered. We also have a great partnership with the department's Office of Analytics. They've been instrumental in helping us with analytics and helping develop dashboards that we will be posting publicly so that anyone can monitor what we're doing, and application status, telephone statistics, all of those different unwind data points will be available publicly for all stakeholders. So we also spent a significant amount of time developing our operational unwinding plan, which is a beautiful document if you would like to go see it. It's posted on our website. It's about 52 pages. It's a really comprehensive, detailed document of every step that we've taken along the way. And one of the things I would like to highlight as part of this process is what's called ex parte renewals. So ex parte is Latin for by one for one party. So what that means is we have the ability to hit different databases to automatically determine if someone is eligible for Medicaid. And if so, we can then automatically renew them and send them a notice and tell them you've been renewed for 12 months. So why that's key in this process is because, well, number one, it's mandatory by CMS, so that's a big factor. But so we did start that process in December, and in December we were able to renew just over 16,000 households without them having to do anything, without a caseworker having to touch their case. So that's a really huge improvement for our state to simplify things for members and ensure continuous coverage. Some exclusions from ex parte are based on aid code, the Nevada Checkup Program, and then also there's scenarios where folks might have a pseudo social security number, and we can't hit a database if we don't have a valid social security number, so it just isn't logical. Another thing I'd like to highlight as part of this project is Georgetown has a 50 states tracker posted online of the five key documents that are posted publicly. Nevada is one of 10 states that's hit all of these 5 points, so it's always nice to highlight when we're in the top 10 for anything. So those things are state plan or summary, alert to update your contact information, unwinding frequently asked questions, a communications toolkit, and unwinding data dashboard being posted publicly, which we do plan to start once the unwind actually, we have to have data after, so it'll probably be around May timeframe. So that concludes our unwind efforts. I'll turn it over to Deputy Contrell.
Good afternoon, Madam Chair, Vice Chair, and committee members. For the record, I'm Kelly Cantrell, Deputy Administrator with the Division of Welfare and Supportive Services, and I'm happy to be here today to talk to you a little bit about, well, they covered most of it, but a little bit about DWIS's part in the unwinding and collaboration that we've had, and then a little bit about some of our programs and things that are updating and happening within welfare. Sandy did a great job touching on the fact that we received a waiver to use the National Change of Address database and the managed care organization addresses that they received as verified on receipt. So what we did is we went in and we put a team together that we dedicated specifically to the address changes. So they do nothing but update the eligibility system with these verified addresses that we receive. And they also go and reach out to customers if we need to do that. So if they receive an out-of-state address or return mail with a forwarding address, they will reach out to the customers to see if they can verify the address that we've received or that information there. And as an interesting note, in 2022, we were able to update nearly 267,000 addresses. Which will go a long way to help in the unwinding process, because one of the things we're really afraid of is not being able to reach the folks to let them know that this is happening or that their Medicaid needs to be redetermined, because it's just been rolling along now for, what, over 3 years?
Yes, 3 years.
Yep. Yeah. One of the things that's a notable mention is the state of Nevada, DWS says, we did not make any system updates to provide continuous coverage. We were able to do it with staff and supervisors doing overrides so that people stayed eligible for what they were eligible for. So as we start to unwind, we don't have any system updates to unwind. So that'll make it a little bit easier as we move into this. As you heard Stacy say, there are over 900,000 Medicaid recipients, and that sounds daunting, like a daunting task to certify everybody or redetermine everybody in the year. But at DWIS, we work with cases, not necessarily individuals. So that over 900,000 individuals translates to 535 cases, which will then be worked over the coming 12 months. The majority of those cases have what we call SNAP. SNAP is Supplemental Nutrition Thank you. Assistance program. What a place to lose my train of thought. Those cases are renewed, the majority of them are renewed every 6 months. So the cases that have a combination, which is about 50% of our Medicaid cases, we haven't lost touch with those individuals. We've been seeing them, talking to them, getting updates from them every 6 months with that program. Stacy did a great job covering all the various ways customers can apply, access Medicaid, so I won't reiterate that, but they're listed here on the slide. Okay, so let's talk about the DWSS programs. So the first one we'll talk about is Temporary Assistance for Needy Families, which you will hear referred to as TANF. And TANF is designed to provide assistance to care for dependent children in their own homes with their own parents, relative caregivers, fictive kin, so kind of like family, real close family relation, or friends, family friends that can care for the child instead of placing them in a random foster care system. TANF provides financial support and supportive services such as transportation, vocational training, work permits, tools, anything work-related or related to getting a job, those type things there. The next program I'd like to talk to you about just a little bit is the Energy Assistance Program. You'll hear that referred to as EAP a lot of times when we speak. And that provides a supplement to assist qualifying Nevadans with the costs of energy. So it reduces the burden of those high electric bills, sometimes those gas bills. It helps residents get through the hot summers, right, down in Las Vegas, and those cold winters up here in Reno and Carson City. So that's a program I'm super excited that we have. Child Care and Development, CCDF, assists income-eligible families with the cost of child care so that they can go to work, and it also helps them find quality child care that's out in the community. Child support enforcement. So this aims to make child support a reliable source of income. They want children to have financial and medical support from both parents and not just one. So they strive to see that that happens. It emphasizes the need that children have to have both parents involved in their lives, and all at the same time it helps reduce the welfare costs. So the next slide, we're going to start here talking about SNAP, or Supplemental Nutrition Assistance Program, which was formerly known as food stamps. So that's a term that a lot of people are familiar with. Food stamps helps qualifying Nevadans buy food. For some Nevadans, after paying rent and utilities, they have oftentimes very little money left to buy food. And so this program helps them buy nutritious food. Thousands of families across Nevada receive SNAP benefits every month to help feed their families. Okay, so let's talk about Supplemental Emergency Allotments, or SEA. There was a news article, there's been several recently about it, and so I want to talk to you a little bit about this. So DWSS, we implemented Supplemental Emergency Allotments, or SEA, for recipients of SNAP, so the food stamp program, due to the impacts of COVID-19. And what SEA did was increase SNAP benefits, and they started that increase back in March of 2020. And from March of 2020 through January of 2023, we have issued over $1.2 billion in SEA benefits to over 450,000 Nevadans. Huge numbers. Monthly in 2022, we issued $43 million a month, and that served over 230 SNAP households. SEA payments are ending. They end this month. And the last payment that we'll issue in SEA is next month. Okay? So what does this look like? So I wrote down kind of a little scenario, so this will give you an idea of what's happening to these folks starting April 1st. So a single person household, which is about 140,000 of our SNAP households, have been receiving a maximum allotment of $280. So after SEA ends, so starting in April, the amount that will be received by a single person household will be reduced to $149 a month. That's 47% reduction in SNAP benefits that they've been living on for the last 3 years. And that's just going to come to an end. It doesn't unwind, it doesn't, right? It's just ending next month. DWSS is working, we're working with community partners, food banks, the Retailers Association to get the word out. We've got our own people in the field notifying customers. Any interaction we have, we're trying to get the word out so that people at least know that this is coming. Okay. All right. The last program that I'm going to touch on today is known as our Targeted Outreach Partnership Program. It's from, we call it TOP. And TOP basically connects people to DWSS services throughout the community. We all know, or we recognize, that sometimes there's a stigma with applying for welfare, being on welfare, walking into a welfare office. So by mobilizing and putting our people places where you wouldn't normally find them, it allows us to reach underserved members of our community who may not walk in. Members of the TOP team take applications, they make changes, they make eligibility determinations, they issue the SNAP card or the EBT card, the benefit card, and more. They have what's called an office in a box. So they basically pick up their laptop, a scanner, a printer, and they travel. And they travel from place to place out into the community. And it allows them a lot of efficiency, and it allows them to be very productive without having to be in a traditional brick and mortar welfare building. We have 48 family services specialists, which are our eligibility staff, on the TOP team that serve 182 community sites every month throughout the entire state of Nevada. We service some of them in person, some have asked us to come virtually, phone calls, all different ways this team services rural areas all over. So an example of some of the sites that we have social services sites such as county social services offices, libraries, counseling centers, schools, homeless shelters. We have medical sites such as hospitals, rural, tribal behavioral health clinics, and we have a lot of justice-related sites such as correctional facilities, sheriff's offices, courthouses. Down in Las Vegas, for example, we have 3 of the TOP team stationed right in CCDC, the correctional facility, and that's their home office. They go there every day. They report to work there. That's what they do every day. In 2022, the TOP team attended 132 specialized events, and that was a slow year because we were just coming out of COVID, right? So we anticipate a lot more this year. But they go to things like, I jotted down a few of them here. So they went to the city jail inmate resource fair, Reinvent Schools Safe Summer Nights. They attended the Black HIV/AIDS Awareness Event, U.S. Veterans Job Fair and Community Fest, Washoe Tribal Health Festival, and a myriad of other health fairs, Elko Veterans Roadshow, just to name a very, very few. We've even gone to grocery stores and have set up right outside the market so that we could be there for anybody walking into the market that may have an interest in some of our programs. So it's very, very flexible. Currently, we have 89 community-based organizations on our wait list that are requesting staff, TOP staff, to utilize these outreach services in their facilities. And that is the last of our presentation, and I think that we're all available to take any questions that you might have. Thank you.
Thank you so much for the information sharing. I think several of us are new to this area and we're unaware of many of your programs. So we have quite a few questions. I've got a list going, so we're going to go through them. I just want folks to be aware that I'd like for us to be able to get out of here around 3 o'clock. That's my goal, but I do want to enable you to address all your questions. We have these professionals here, really the folks who know the secret sauce of how this all works. So ask your questions, but if we can keep it concise and keep comments down, we can get more information out of them. I'm going to go ahead and start with Assemblyman Hafen, and I see you over there.
Thank you, Madam Chair. And I have to begin by saying thank you for all that you do. It's a lot of work, and just looking at slide 3, 920,000 people that you guys have got on Medicaid, which was, and I'm a numbers geek, so I'm writing down the numbers. I'm looking at where we're at. It looks like about a 250,000 person increase since 2019 and the pandemic, and that's just an amazing feat. So I have to thank you for that. But I do want to question, I believe you said that in 2019 there was about a 10% uninsured rate, which was roughly about 300,000 people. And I know the addition of the 250,000 is not one for one because people lost their jobs and businesses went under during the pandemic. Do we know when we'll actually have an update of what the percentage is of uninsured? It's somewhere between 1.5% and 10%. And I just kind of curious, so, when we're sitting up here, if we'll have that information this session, or if that's something that we'll have to wait to get in the interim.
Stacy Weeks, Division of Healthcare Financing and Policy. Madam Chair, through you to you, Assemblyman.
Please go directly to the member.
Oh, thank you. Thank you. It's a good question. Honestly, it's hard to find that out. I think the entity that probably can give us that update would be the Department of Insurance. We can follow up with our sister division or department. I will say the latest data that's online from the Kaiser Family Foundation was back in 2022 or 2021, so it's even behind a year. So I think even once you do get that update, it's still not really going to reflect probably all the gains that have even been made in the last year. So it's a really hard number to pin down, but we can definitely follow up with our Department of Insurance colleagues and try to get an answer for you.
And Mr. Ashton has offered to have some input on this, so I'm going to let Mr. Ashton go ahead and answer.
For the record, Patrick Ashton, Research Division, Legislative Council Bureau. So according to the 2023 Insurance Market Report from the Division of Insurance, Department of Business and Industry, the current uninsured estimate is 10.6%, an estimated account of 333,000 Nevadans without insurance. Thank you, Madam Chair.
Thank you. And as a side note, I think as we see the unwinding happen, we're trying to capture all those folks so that we don't have an increase in that number. And that's really the feat right now, is making sure we have all the right things in place. And it is really truly amazing that we've gotten to a place where we have a plan to do that. I have Assemblyman Nguyen next.
Thank you, Madam Chair. And before I get to my question, I just want to reiterate what I said on our last meeting is I have utmost respect for the Health and Human Services staff. You all have so much to do and so little time, and it's always endless things. So I appreciate that you all still here with a smile and ready to take on the challenges. So much respect. With that said, I'm a data guy, so I always wanted to really see how we can be helpful with data in terms of what we can do as part of what we do on this side of the aisle. But in terms of, you mentioned earlier, this is a dashboard that you're working on that kind of put in real time things that everybody can just look at from the public standpoint and even the legislature. Looking at these big project that you're taking on with the unwind, with the SNAP changes, with the SDA changes, are there plans, or maybe there's already existing data profile that we can look at as members in our respective district by assembly district in terms of where the numbers are, so that, let's just say, if I represent District 8 and the number is this much, and my colleague on District 16, her number is this much, are there data available for all these programs across the department programs that we can see, and then we can truly, help you all in terms of outreach and be able to bring more attention to it?
Madam Chair, Stacy Weeks, Division of Healthcare Financing and Policy. I'd like to call up Kyra Morgan, our Office of Analytics Director.
Thank you, Ms. Morgan. Please go ahead.
Hi, I'm Kyra Morgan. I'm the State Biostatistician for the Department of Health and Human Services. In the Public Health Unwind dashboard, we are adding a mapping feature, so you'll be able to look at where these individuals who are losing coverage live. I do have a static report that I could provide to the committee that looks at the individuals who we already know are more likely to lose coverage because of, for example, they have submitted income under SNAP redetermination. So we have a lens into people who are more likely to lose coverage, and we have that mapped by zip code currently, so you can see where those folks are living. We also do have on our website the legislative health profiles. Those allow you to look at a breadth of information, including eligibility for Medicaid, SNAP, and TANF, which is Assistance for Needy Families, as well as just general health indicators, so cancer rates, mortality rates, drug use rates, really a wide array of things, and those are all available on the website. So I can provide those links.
Thank you. May I have a follow-up?
Please go ahead.
Great, thank you, Chair. The next thing that we talked about earlier, right before we end, was the targeted outreach partnership. My question is, in terms of that funding source and in terms of where that comes from to execution of that program, because I think it's a great program. I just didn't know about it. And then if you can also provide to me the definition of non-traditional communities.
Kelly Cantrell for the record. Thank you for the question. So the majority of the funding for the Targeted Outreach Partnership Team is federal funding through the SNAP program. And so the types of places that we go non-traditional would be places like jails, correctional facilities, hospitals, schools, libraries, sheriff's offices, just anywhere that we have people asking for us, that's where we put our folks, but it's just all types of different places such as that. Homeless shelters, we're in homeless shelters. We're in Las Vegas, we're in the courtyard, which is an entire homeless courtyard, for lack of a better word, and we have 10 outreach members that are stationed there. So it's just all those places that you wouldn't we're even in a dental school. And so all the places that you, outside of welfare office, that you wouldn't necessarily expect one of our eligibility staff to be, those are the places that we're trying to get into. You're welcome.
Thank you for the question. Assemblywoman Newby.
Thank you, Madam Chairwoman. Thank you for the presentation. I actually have two questions. First, on slide number 11, I believe it is, what does Medicaid cover? I didn't see any mention of mental health or behavioral health on that list. So question number one is that covered by Medicaid? And then on slide number, 14, when you speak of the state share at 39%, where does that money come from?
Thank you, Madam Chair. Stacy Weeks for the record, Division of Healthcare Financing and Policy. For your first question, yes, behavioral health is covered. Often, sometimes the way it's written into federal law, it's usually by, you can see there's some of those are provider types, but services or behavioral health are essential benefit that are required to be covered. In answer to your second question, that is the state budget. So that is the appropriation that the state has paid us for that state share that we pay for. So when we add a benefit, we need to come and get legislative and budget authority to pay for that service, or we can't actually fund it.
Please go ahead.
Quick follow-up. My understanding is that, at least in the past, Clark County had an agreement with the state to contribute funds. Is that still the case or no?
Yes, sorry, NIGT. Yes, so intergovernmental transfers. So there are other smaller sources of state share that we can get from local governments if they would like to front the state share. So my apologies, yes. Typically, though, it's a state general budget.
And those are considered, those are only considered under waiver programs, right?
Madam Chair, Stacy Weeks for the record. No, they're a way that we can, so the federal law allows us to do intergovernmental transfers from a local government to fund the state share. And so in that example, it allows for us to pay a supplemental payment to the hospital in addition to our base rate. So it doesn't have to be through a waiver.
Thank you for clarifying. I have Assemblywoman Thomas next.
Thank you, Madam Chair. Same page. And thank you for the information that you're giving, because there's so many questions that I had as far as Medicaid that I think your clear, concise way of explaining it brought it home for me, and I do appreciate that because I am a layman in this area. My question is, when we say the federal share is 61%, you gave a minimum, and I think the minimum was 50%. What's the maximum?
Madam Chair, Stacy Weeks for the record. I'm not quite for sure there is a maximum. I can't imagine, though, it would ever be 100% because then that would violate federal law, which says there has to be some state share. But no state can get less than 50% from the federal government.
Follow-up, Chair, please.
Please go ahead.
Thank you, and thank you for that answer. So my question is, can we ask, I guess, our federal delegation to see whether or not we can get an increase? Because, I've heard from so many different committee members that this is the problem, that if we had more money for Medicaid, we could, service our growing population that needs or requests Medicaid services.
Madam Chair, Stacy Weeks for the record. Now you're singing my song. There's always a need for more money. Unfortunately, the FMAP is set by federal law, and there's a formula, and that formula spits out a number. And right now, ours is at 61%. It went down, and that's because our per capita income went up for families. So it really fluctuates based on poverty in a state and per capita income. So like, for example, Mississippi, which is one of our more impoverished states in the country, they have a much higher FMAP than us.
Thank you. I appreciate that. Thank you, ma'am.
It's an important question. I think several of us were wondering how that fluctuates, and especially looking at the cost of living increase that we've seen in the state. How is that incorporated into the FMAP funding formula? Do you know if it is even considered?
Madam Chair, Stacy Weeks for the record. I'd have to give you probably the exact formula if that's helpful, but it's per capita income does look at sort of that poverty impact. So I hear what you're saying, but I want to follow up before I try to answer that question.
I appreciate that.
Thanks.
Thank you so much. I have Ms. Gonzalez, Assemblywoman Gonzalez, next.
Thank you, Madam Chair. Cecilia Gonzalez, Assembly District 16 for the record. I was curious because I didn't see it on the slide about services, if Medicaid covers mental health and what that looks like.
Madam Chair, Stacy Weeks for the record. Yes, we do cover mental health, substance use disorder treatment, behavioral health, a variety of services. We can follow up with a full list.
Thank you so much. Follow up, Madam Chair.
Please go ahead.
And then Cecilia Gonzalez, Assembly District 16 for the record. And then I had another question. Something that I hear from my constituents often is really the quality of care. And so what is your organization doing when it comes to having a diverse, quality care for your constituents that utilize this service? Thank you.
Madam Chair, Stacy Weeks for the record. That's a really good question, and it is a concern. For us, I will say in our fee-for-service program, we don't really have any tools to implement or really require quality like we can our managed care program, which it does. We do measure our managed care plans on a lot of different quality metrics that are required by federal law. I will say our recent procurement, and so for this last contract period with the plans, we do have a lot more quality strategies, population health management strategies. They're also required to look at their workforce and make sure that it's diverse. And there's a lot more, I think, tools there for us, and that is 78% of the population. But as you know, it's not everyone. So it is an area we can grow in. Thank you.
Thank you, Madam Chair. Thank you so much. And, I just try my best to be bringing the concerns of my constituents forward. And, that is something that I hear a lot. And so thank you so much. And I look forward to working on this with you all.
Thank you. Thank you so much for the questions. Assemblywoman Taylor also had a question, but she had to step out for a moment. So I'm going to ask a couple of questions. Oh, I'm sorry. Assemblyman Gray, you were on my list. Please go ahead.
Thank you, Chair. So you guys do a great job. You guys are out there. I mean, I represent a portion of the rules, and you guys do, a fantastic job. It's a very altruistic job. The question I have is, you guys do a great job of tracking how many people you enroll and you assist and help. is there another side of that coin where you guys are identifying the underlying problems, why they aren't self-sustaining and self-supporting? And are you guys doing anything about that? And also, do you track when people get off whether or not they've moved on to a self-sustaining, kind of lifestyle? I mean, I personally, I think that should be the goal. So there's more resources, that are freed up for other, for other people that need it. But
Madam Chair, Stacy Weeks for the record. Those are really good questions. To the point about tracking individuals when they leave the program, we do not currently track them as far as I know. I know it's not part of our requirements too. I would just note that. But also, there are different components, especially in our managed care program, which really focuses on, I think, some of those employment services and trying to help wrap around people, some of those social services that help provide more stability in their lives and help improve their income so they can move out of Medicaid, right? It should be a ladder up, right, not down. But I think your points are important, and at this time we don't necessarily track, but also coming into the program, we don't also really assess what is the issue of why people are in poverty. I think it's a broader question for maybe a different, probably, department than ours.
Thank you for the question. I have a couple of other kind of base level questions around Medicaid coverage and the relationship with MCOs. First of all, you mentioned just recently the quality assurance metrics from the new contracts with MCOs. Do you anticipate having a report of that or something you can share with our body on what you're finding?
Madam Chair, Stacy Weeks for the record. Yes, in fact, we have a quality strategy plan that we have an updated version I can send to you, and as well as a report on their performance.
Fantastic. If you would send that to staff, and they will send it out to the rest of us. Okay, so on your Medicaid slide, you mentioned that Medicaid is at no cost to the consumer. Does that include co-pays in Nevada?
Madam Chair, Stacy Weeks for the record. Yes, no co-pays and no premiums in Nevada.
Wonderful. And then in kind of the same slide area, you mentioned buying into CHIP. Can you talk a little bit more about what you meant by that?
Madam Chair, Stacy Weeks for the record. Yes, so under our CHIP program, which is called our checkup program, it's for children who are not eligible for Medicaid, so they're above that 165 or 139%. If their families can pay a quarterly premium to enroll into the program, and that's currently how it's structured.
Is that a set rate or is that on a sliding scale right now?
Madam Chair, I'd have to follow up with you on that.
Thank you. That would be appreciated. All right. Well, that was all of my questions for today. So are there any other questions from the committee? I will ask Ms. Taylor to follow up with you when she has the opportunity. Thank you so much for the presentation today, and I want to reiterate what my colleagues have said. Thank you so much for the work you do in our state. We appreciate it, making sure that some of our most vulnerable populations are captured and taken care of in our state, and we look forward to working with you to make sure you have the resources you need and that our state's moving forward to ensure we have a healthy community. All right, we're going to move on with our agenda items. I believe our last agenda item for today is public comment. So I'm going to go ahead and open up public comment. We're going to keep public comments to 2 minutes to avoid and ask that folks avoid repeating comments from the previous speaker. You can always come up and say ditto. Staff will be timing each speaker during public comment to ensure we have fair opportunity to speak. I ask that you clearly state and spell your name for the record. It really helps our secretaries when they're transcribing our minutes to ensure we have those names spelled correctly and clearly. We will begin in our physical locations, first here in Carson City. Is there anyone in Carson City who would like to approach the podium for public comment? Seeing none, I will go to Clark County, Las Vegas. Is there anyone in Las Vegas who would like to provide public comment? I can't see the rest of the room, so I give them a moment to pop into the screen. All right, nobody in Las Vegas right now. BPS, will you please check the call-in line and see if there are folks who would like to provide public comment?
Chair, the public line is open and working. There are no callers at this time.
Thank you so much. Seeing nobody in Las Vegas, I will go ahead and close public comment for today. Before we adjourn, are there any comments from the committee? Well, I hope you all have a wonderful weekend. Nice job on our first week of session. This is really the ramping up to what will end up being a really great session, I believe. Thank you all for being here today, and thank you for those folks who attended in the audience and who presented today. Our next meeting will be on Monday, February 13th at 1:30 p.m., and the agenda will be posted and sent to members when it is prepared. And with that, the meeting is adjourned.